I think we should start. So this morning's talk is from our department, and the presentation is by Dr. Barbara Makumbi. She's going to tell us about tips. Over to you, Barbara.
Thank you very much, Dr. Seabi. Good morning, everyone. My name is Barbara Makumbi. I'm one of the Gastro and Hepatology Fellows at Joburg Gen, currently rotating at Witwatersrand Gordon. I decided to do the topic of tips to explain the procedure, possible complications of the procedure, but I'll give you an overview of cirrhosis and portal hypertension to begin with. So to begin with, I was illustrating the liver anatomy, just to remind us of what the liver actually consists of. The liver is divided into segments, 1 to 8, and you have anatomical anatomy in terms of segments and functional anatomy. I won't go into too much detail just for the sake of time, but I thought it would be interesting and useful for us to just look at the picture on the right-hand side, where it shows a hand, a clenched fist, as a shortcut in order to remember all your segments. So this is something that I'd advise our registrars and students to look up as well. In terms of the blood supply of the liver, to briefly go over it, the liver gets 40% of its oxygenated blood from the portal vein, 60% of its oxygenated blood from the hepatic artery, and total blood volume of 70% from the portal vein and 30% from the hepatic artery. The portal vein is formed by a confluence of the superior mesenteric vein and the splenic vein, and in the hilum divides into the right and left branches. The hepatic artery arises from the celiac trunk. So basically the liver has a dual blood supply. Quickly to highlight some histology of the liver has non-parenchymal cells as well as parenchymal cells. The non-parenchymal cells important for this talk are the Kupffer cells, which are found in the sinusoid, and the hepatic stellate cells, which are perisinusoidal. These actually need to be activated, and if they're not activated, they usually store vitamin D. When activated, they become myofibroblasts, and when they're myofibroblasts, they actually contribute to liver fibrosis, which we'll come to later. You also have sinusoidal endothelial cells, which are fenestrated, and parenchymal hepatocytes, as well as cholangiocytes too. In terms of further histology, we actually have your lobules within the liver. You have your portal triads, which are on the periphery, and your liver is actually divided into 3 zones. So zone 1 is, as illustrated in this picture, has the highest oxygen content. In terms of function, that's where gluconeogenesis takes place. It's close to vascular supply. And zone 2 is intermediate, and zone 3 is your perivenular, where you have low oxygen content and glycolysis takes place. As a quick overview of that. To remember and highlight cirrhosis as a whole, cirrhosis is basically a diagnosis made on histology, but at the bedside, we can make a clinical diagnosis in terms of the signs and symptoms. You have diffuse hepatic fibrosis and nodular regeneration with fibrosis. As I mentioned, you have your hepatic stellate cells, and these can be activated. They can deposit collagen, and there are a lot of growth factors and immune cytokine activation that take place, which are beyond the scope of this current talk, but it's quite in depth. Just so our students and registrars do remember that you'd have different signs for chronic liver disease, different signs for portal hypertension, different signs for ethanol-induced or ethanol-related liver disease, which you need to distinguish. What I've shown here are spider nevi. You need to remember the characteristics of the spider nevi. Remember palmar erythema, and this is a nice diagram just to summarize most of the signs and symptoms that you could find in these patients. We use prognostic scores in cirrhosis, namely the MELD score, which has evolved over the years. You have a modified MELD, but now we're using the MELD with sodium. Sodium is very important in prognostication, especially in patients with Ascites. In the MELD sodium, you look at sodium, of course. For patients who've been dialyzed previously, Their creatinine, bilirubin, and iron are important. The child Pew score is another important score. Sorry, can you mute? Can I ask everyone to please mute? Thank you. So the child's Pew score is another important score that we use. It is divided into A, B, C, depending on the numerical score. You have hepatic encephalopathy and ascites, which can actually be quite subjective in terms of rating and classifying the severity, depending on who's actually classifying what. Then you have your bilirubin again. Here you have your albumin and your INR and PTT. Your prognosis, so these are prognostic scores that I've said, initially developed for actual tips, mortality post-tips initially, but we also use these scores for organ allocation for transplant now. Other scores that I thought would be important to highlight are your non-invasive fibrosis scores. So assessing fibrosis in cirrhotics is an important prognostic indicator of severity of disease. And instead of doing liver biopsies, which are actually the gold standard still, but very invasive and can have high risk, you can use a score called the APRI score, where you use your AST and platelets, or your FIB4, age, AST, ALT, and platelets can be used to determine and estimate the amount of fibrosis a patient may have. And if you're fortunate enough, a fibroscan can be used as well, looking at the kilopascals. And this can estimate if more than 14, likely cirrhosis, more than 21, likely to develop portal hypertension, etc. And MRI, etc., can also be used. The stiffness in these two scores can actually be overestimated. It can be overestimated in patients that have active inflammation, if patients have congestion in terms of heart failure, right heart failure in particular. So it has to be used with discretion. Moving on to portal hypertension itself. Portal hypertension is increased hepatic sinusoidal pressure more than 6. You develop portosystemic collaterals. In terms of your portal circulation, you have basically your capillaries from your esophagus, your gastric capillaries, small and large intestines, pancreas, gallbladder, and spleen that go via the portal vein to the liver, to simplify it very, very, very simply. Your hepatic sinusoids then are located in your liver. And there's an interplay because you have your hepatic artery also supplying the blood supply. So your hepatic artery and your portal vein supplies the sinusoids to maintain arterial inflow. And they actually have autoregulation. They compensate for each other. For example, if somebody has a portal vein thrombosis, then the hepatic artery flow will increase in terms of compensation. I just highlighted the portal vein is plus minus 7.5 centimeters normally. And in terms of pathophysiology of your portal hypertension, important factors are your nitric oxide. Nitric oxide is derived from the endothelial nitric oxide synthase, ENOS. This results in vasodilatation. It's stimulated by shear stress. Endothelin 1, ET1, is also important, and this results in vasoconstriction. I'll elaborate further later. In terms of the portal hypertension pathophysiology, I thought this was a very nice diagram to illustrate the different factors that are in play, but it is an overview, like I said. You have architectural changes, fibrosis, vascular remodeling, and regenerative nodules that all increase intrahepatic resistance. So that's one of the main components. Vasoconstriction, elevated vasoconstrictors, reduced vasodilators, your nitric oxide, and sinusoidal hypercontraction, elevated hypervascular resistance, it's increased. With that, you then get increased portal flow. You have increased splanchnic arteriolar vasodilation, which is increased nitric oxide in your splanchnic and systemic circulation, while it's different in the liver. And splanchnic vascular cells also basically, they get deregulated. So there's increased vasodilation in the splanchnic circulation as well as your systemic circulation. So that's the basic the basic principle of this: intrahepatic resistance and splanchnic and systemic vasodilation. You have collaterals that then dilate, and you have angiogenesis. I've already highlighted what's been said on the slide, but just to add that the hepatic stellate cells also contract, which we've mentioned in the sinusoids to increase that pressure intrahepatically. Hyperdynamic circulation is basically the portal inflow that I've mentioned with the vasodilation and peripheral vasodilation. And that results in the decreased mean arterial pressure. And then as a means of compensation, you have an increased cardiac output. So in the beginning, these changes in the body can be compensated. But as things get worse, obviously the compensation decreases. I just wanted to highlight how we measure portal pressure. Very it's an overview basically, is detailed, but the hepatic vein pressure gradient is an important factor. This is done with a catheter that is an indirect measure of the portal pressure. You basically have a catheter that's wedged between the hepatic venous pressure, and a difference between the free hepatic vein pressure. There's also splenic pulp pressure, which is a more direct way with a catheter that's inserted in the splenic pulp, and that's quite invasive. Just to highlight aspects of pharmacology related to the physiology I've discussed briefly. Statins are actually, I said that first, though it's not something that's commonly used because it's quite topical at the moment. Simvastatin has been studied to decrease portal pressure. It may activate the nitric oxide enzyme and decrease intrahepatic resistance, also maintaining hepatic flow. So that's something that's been studied. I think there should be a few papers out on that. Then we look at the ET1 antagonists. These were something that we looked at, but have hepatotoxicity, so that doesn't work. And then related to your nitric oxide, mononitrates have too many side effects and are generally not really used. In an emergency, we use octreotide. So octreotide in a variceal bleed, it's a synthetic analog of your somatostatin. It inhibits glycagon. This results in constriction of splanchnic circulation. With that constriction, there's decreased portal vein inflow. So there's that decreased flow, and this is also very important postprandially. And we use non-selective beta blockers generally. Usually here we use propranolol, but I'll get onto the other beta blockers now. So propranolol, non-selective. So B1, cardiac and heart rate decrease. And then you also have your B2 blockade with vasodilation of the mesenteric circulation, but unopposed adrenergic blockade. So you actually have a decrease in inflow of portal inflow. Now, CARLOC is what we're starting to use in our more compensated patients with Child-Pugh A and B. CARLOC is nice because it's also non-selective. However, it does have adrenergic A1 blockade, whereas propranolol doesn't have any adrenergic blockade. So with the decreased heart rate, decreased cardiac index, your splanchnic vasoconstriction, and then decrease in hepatic vascular tone, but as well as arterial hypertension as well. So basically with CARLOC, you have the two mechanisms being combined mechanism of decreasing your portal pressures and treating these patients. You have a decrease in your intrahepatic resistance, as well as a decrease of the inflow. So we're using those now. Just as a reminder of the sites that we get varices and portal hypertension, it's not only the esophagus, you get gastric, splenic, you get paraduodenal, your paraumbilical, your caput medusa, and rectal, as well as patients with stomas, they can get peristomal varices. I was going to highlight more on the management of varices endoscopically and pharmacologically. I think I've touched on that briefly, but for time's sake, I'm going to not do that now. Moving on to ascites. Briefly, the pathophysiology is based on your renal sodium retention. This is your renal angiotensin-aldosterone stimulation and your sympathetic nervous system, as well with norepinephrine. So you basically have a systemic circulatory disturbance. This is as a result of splanchnic arterial vasodilation, which we've discussed. So because of that, you have impaired sodium and solute free water excretion, as well as with renal artery vasoconstriction that can occur and decrease your EGFR with your renal, with activation of all these systems. That can also lead to HRS. Generally, you have chronic inflammation, and this is also contributing to your impaired circulatory function. I thought this was a very nice summary of Ascites in general. They talk about diagnostics. They talk about looking at your SOG. So a SOG above, they say 1.1, that's American. So we look at a SOG more than 1.11, sorry, for portal hypertension. They talk about the diagnosis of SVP, more than 250 white cells, neutrophils. And then also, in terms of management, so I've highlighted sodium. That's an important factor in like management of ascites. Diet, decreasing your sodium intake to less than 2 grams a day. So basically telling a patient, look, don't add extra salt to your food, don't eat takeaways, try and prepare your own food, because it's very difficult to actually decide how much this is actually in terms of the amount. So that's the advice you give a patient. I'm going to glaze over diuretic therapy, but also like illustrate that plasma aldosterone that we mentioned, the renin angiotensin aldosterone system. Aldosterone is very spironolactone to inhibit this is very important. We use this with furosemide, but that's a long discussion, either with or without. If we're using them together at a ratio of 100:40, and also more details are in the slide. I think I'll make the slides available later. They talk about LVP, large volume paracentesis. We use albumin when we are draining more than 5 liters of ascites, and that we also do use albumin in HRS, I'll just mention. And tips I'm going to talk about extensively. So I've also mentioned here that the fractional excretion of sodium is quite important in our management of our ascites patients, especially patients that are refractory or resistant, to see what's, to quantify their disease, as well as that you also have interleukin 6, interleukin 8, and TNF alpha that play a role with inflammation. And it's important to note that these patients have bacterial translocation, and keep that in mind. Another complication of portal hypertension is portal hypertensive gastropathy. And this is another complication too, would be your GAVE as well, your watermelon stomach. So when we scope patients, we look for a mosaic pattern of the mucosa for the portal hypertensive gastropathy. It's usually more distributed versus the GAVE that's antral and linear. And these pathologies both have different histologies. So in terms of treatment, when we see this, you can actually have both of them, but you need to distinguish between the two because the management of the two is different. And also stems into the fact that portal hypertensive gastropathy can be treated with tips, which I'm going to elaborate on now, whereas GAVE doesn't respond to tips. Excuse me. So the history of tips. TIPS was first actually discovered years before 1988, but first used for variceal bleeds in 1988. Initially, when they started doing the procedure, they used to take 8 hours to do the procedure. Then in 1990, an ultrasound guided procedure was discovered, and this decreased the time. And with years going on, there have been developments. So initially, they used it for variceal bleeds, then later for ascites, and also discovered that, like before, we were using bare metal stents, which actually had increased stenosis quite quickly. So there's bile-resistant coating now, which are covered stents that we use that are the modern stents, and these increase patency, duration, and mortality. So what is a transjugular intrahepatic portosystemic shunt, or stent? Basically, TIPS allows for a reduction of an elevated portal pressure. It creates a communication between your hepatic vein and an intrahepatic branch of your portal vein. We use interventional radiologists to do this procedure, and it's a percutaneous approach with jugular cannulation of the hepatic vein, and a guide wire is passed through. The tract is then dilated and a stent is placed. Like I said, a coated stent these days, and it decreases the frequency of stenosis. And we decrease the portocaval pressure. The pressure difference between the portal vein and IVC at the confluence of the hepatic vein of less than 12 is ideal. So looking at the workup for TIPS, the workup for TIPS includes preventing complications. That's important. And the main complication, one of the big complications we worry about is hepatic encephalopathy. So all shunts will cause hepatic encephalopathy, or have the risk of causing or precipitating or worsening hepatic encephalopathy. So every effort must be made to identify any patient at risk of developing this, especially for elective TIPS. Emergency may be, it's more difficult to assess, but for an elective patient, it's essential. There are some criteria that do help decide if a patient is at risk, including a history of previous overt or even covert hepatic encephalopathy. A patient that is over the age of 65 is a high risk, but these aren't solid, and they're not absolute, contraindications. They're looking at diabetes that may reflect an altered renal handling of ammonia, which is not something we particularly exclude, but it's something to think about. That's in terms of renal excretion of ammonia. And the severity of your liver disease. So the cutoff for your child Q is more than 10. And like I mentioned, the covert hepatic encephalopathy and subclinical encephalopathy may not be diagnosed. A patient needs to be screened before they have the TIPS, and there are a number of tests, one of them being the Stroop test, and a number of apps, etc., that you can go through and download, like psychometric investigations, or get a psychologist to assist as well. So if a patient does develop hepatic encephalopathy, there are options to maybe decrease that. The first thing would be to treat as you would normally with your lactulose, like nocturnal sedation, correct all the biochemistry and electrolytes, etc. This illustration that I'm showing you does show a patient that did not respond to those treatments. Another thing I didn't mention is rifaximin, sorry. So TIPS reduction is always an option if you really, really can't control the hepatic encephalopathy. Reduction means that you decrease the diameter of the TIPS. You can actually embolize or obstruct the TIPS as well. So by decreasing the shunting, the hepatic encephalopathy decreases. Another consideration is cardiac involvement. Patients with cirrhosis have cardiomyopathy. They have myocardial hypertrophy. They do get prolonged QTs, and these things need to be looked at. ECGs need to be done, extensive history and examination. It's advised to do a pro-BNP, and a TROP-T may be warranted. And if any of these are alarming, then a cardiologist needs to be consulted, and an echo needs to be done, and an assessment needs to be done before an elective procedure. This shunt has a large volume of portal blood going to central circulation, and the cardiac output and the right arterial pressures increase substantially. So pulmonary hypertension that's severe is a contraindication for TIPS. Nutrition is very important. Sarcopenia and malnutrition are definitely complications that our cirrhotics have, and it's important to make sure that dietetics do assess the sarcopenia. These also can accelerate the progression of liver failure, infection risk, hepatic encephalopathy, ascites, etc. In renal patients, there is a bit of controversy with regard to HRS and TIPS, but if a patient does have intrinsic renal disease, stage 4 or 5, it's a contraindication. Also, it's very difficult to differentiate between somebody who's acute, especially with renal disease, acute kidney injury that's intrinsic, acute kidney injury related to their current state, or intrinsic / HRS, sorry. So it's quite tricky to decide. So clinical discretion must be made. So this is basically what I've already said. I just thought it was a nice slide to illustrate that. We've spoken about demographics, renal are highlighted. Liver dysfunction, these are your MELD and your child pew. They say high-risk patients, MELD about 15 to 18, child pew I mentioned about 10, and your pre-encephalopathy workup. Vascular anatomy is important. You do have to image these patients before ultrasound and portal vein Doppler or CT with the liver triple phase, and cardiac assessment as well as nutrition. The indications for TIPS, variceal bleeding and recurrent or refractory ascites are the big ones. So I'm going to just elaborate on that here. In terms of portal hypertensive bleeds, there's a big schema, but just to highlight that there is an established case. Sorry, can we mute, please? Thank you. So there is an established place for the use of TIPS in the management of acute variceal bleeding that is refractory to pharmacological and endoscopic treatment. It's controversial because ESOL say, which is the European liver guidelines, say up to 5 days, and then decide on whether you want salvage treatment. You want treatment, sorry, for acute variceal bleed. But then you also have your salvage therapy, which is also very, very high risk. So they talk about your child pew score less than 14 being ideal for these patients. It's the same, you also need to, for acute variceal bleeds, in a hemodynamically stable patient, there's this new, well, maybe not so new, debate about early and preemptive TIPS, which early being in the first 72 hours of a patient bleeding. In a patient that's, like I said, stable, but then they have to have a child pew C or a MELD above 19. And so this is something that I'll elaborate on in the next slide, but it's something that's being debated. Secondary prevention. Secondary prevention for esophageal varices or GOV, or gastric varices, for a patient that's had recurrent variceal bleed, despite having endoscopic and pharmacological treatment, they should have TIPS. And with gastric varices, who have recurrent bleeding despite endoscopic injection, for TIPS. I'm not going to elaborate on ectopic and other, but I did mention the portal hypertensive gastropathy as well. So as I was talking about the early TIPS with the covered stents, this is a study from the Lancet Gastro. They said standard treatment for acute variceal bleed in a patient with advanced cirrhosis. They took patients in China with a randomized controlled trial, and patients had child pew B or C. So B is kind of controversial, but C, they're saying that you can do it. And they had acute bleed. So they were treated with vasoactive drugs plus endoscopic treatment, then randomly assigned to receive TIPS at 72 hours or 5 days. Early TIPS with the covered stents improved transplantation-free survival in selected patients with advanced cirrhosis and acute variceal bleed. So this is up to clinical debate. TIPS in ascites. So you have a patient that has refractory or recurrent ascites. In the 2016 NICE guidelines, they said TIPS is better for ascites control. It improved transplant-free survival, less complications of renal failure versus like recurrent large volume paracentesis. But with the TIPS, the patients got more hepatic encephalopathy. ESOL actually looked at ascites and TIPS and said, and they had criteria that are suggestive of somebody that would have an increased risk of mortality. Higher risk patients for TIPS, according to ESEL, advanced liver disease, looking at your bilirubin more than 50, platelets less than 75, somebody with current hepatic encephalopathy, active infection, progressive renal failure, and systolic or diastolic dysfunction of pulmonary hypertension. Other indications for TIPS.
Sorry, Barbara. Can everyone please put off their mics and please adhere to it when you join the meeting to switch your mic off. It's quite disruptive to Dr. Makumbi. Thank you.
Okay, thank you, Bob. So TIPS for hydrothorax. Also refractory hepatic hydrothorax is an indication for TIPS. Without going into further detail, it is something that you would consider. And I found this interesting. So TIPS and your alpha pump. So this is a pump that is fully implantable, wirelessly charged pump that continuously pumps ascites from a peritoneal cavity and pumps the ascites into your bladder. I've never seen this, but so you install it and you can actually monitor how much ascites is being pumped into the bladder as a physician. And you can, it looks like it's very convenient for patients. It is in the ESEL guidelines in 2018. I saw that in the UEG, they reviewed TIPS versus and looked at the alpha pump system for refractory ascites. And it seems quite promising. And it maybe should be proposed for management later. I need to look more into the complications regarding this pump, but I thought that was quite interesting. Other indications, we've spoken about HRS, which is very controversial. Some studies have shown an increased improvement in renal function with TIPS, but it's very, very controversial. And TIPS for Budd-Chiari syndrome, this is something that's properly established now. So in Budd-Chiari syndrome, just to remind us, it's defined by obstruction of hepatic venous outflow from the level of the sinusoids to the IVC, any obstruction from that level. Primary or secondary. So your primary, you have a JAK2 positive patient. Most of the ones that, the 50% of these patients may have JAK2 positive or myeloproliferative neoplasm. And then secondary, you need to look for your tumor or and these two examples, or a large hepatic cyst, but obviously the list is very extensive. For Budd-Chiari syndrome, you have a procedure called hepatic vein intervention. If this is unsuccessful, then TIPS is indicated. It's also indicated in acute or small vessel Budd-Chiari syndrome. This is a very technically challenging procedure, and it's very high mortality rate. So a prognostic score has been established for this, and it's very important if a patient does not qualify for any of these procedures to consider liver transplant. TIPS for portal vein thrombosis. So previously it was actually quite controversial to do a TIPS for a patient with portal vein thrombosis. However, now we actually look at the anatomy more extensively, and it actually has been shown to be beneficial to patients with portal vein thrombosis. So it's not a contraindication anymore, especially, so now they say refer to an expert center for a multidisciplinary team discussion, especially patients with acute portal vein thrombosis, cirrhotics, and patients that are actually having variceal bleeds. TIPS has been shown to help with recanalization of the portal vein thrombosis too. I've gone over this, but there are some conditions that I did not mention. We mentioned cardiac, we mentioned pulmonary hypertension, heart failure, and severe valvular insufficiency is also another contraindication. A patient that, so we mentioned severity of liver disease. So if somebody has rapidly progressive liver failure, they're contraindicated to have TIPS. Hepatic encephalopathy we've discussed, uncontrolled systemic infection or sepsis, and then an unrelieved biliary obstruction. Patients with polycystic liver disease have had some successful case reports, but it's also listed as one of the contraindications at the moment, and somebody with extensive primary or metastatic hepatic malignancy. Procedural prep. So I've mentioned you need imaging. You need to inform the patient of all the possible complications. There's high mortality with TIPS, especially when it comes to salvage TIPS. So it's very, very important. And the hepatic encephalopathy, explaining to the family that it can be quite devastating that a patient just suddenly changes their personality after an elective procedure. So it's really important to counsel them. It's done under GA and conscious sedation. It's important to check the TEG. INR is very unreliable in liver disease, but that's a very long talk for another day. And platelets below 50 should be probably transfused during the procedure. Oh, I did mention this, sorry, I think it's in the wrong place, but just to reiterate that large diameter shunts actually cause more likelihood of hepatic encephalopathy, so decreasing the size of this shunt. There's another procedure or type of tips where you can actually have a shunt that's controlled expansion. So you can increase and decrease the diameter and monitor the portal systemic gradient while doing that to optimize the size. So like I said, you can have a smaller shunt, but if you have a smaller shunt, you might not have it working tips, and then there's no point, especially with patients that have ascites. This controlled expanded shunt is quite interesting because you monitor how much pressure you're decreasing, and it may decrease hepatic encephalopathy further. Other complications of TIPS, so early complications are less than 30 days, late complications more than 30 days. I didn't mention hemolytic anemia, and obviously with any procedure that you're having invasive, where you're invasive, you can have injury. So carotid artery injury, you can develop sepsis, cardiopulmonary complications, worsening liver failure on both sides. And then stenosis of the shunt as a late complication, and the stent can migrate. So following up a patient post-TIPS, we don't really do non-covered stents anymore, but there's increased frequency of stenosis. As I've said, you can do Doppler ultrasound. There's no exact times that have been documented for intervals post the initial checkup for Doppler ultrasound. If you are worried and a patient does develop, say, their ascites again, it may be warranted to do a Doppler ultrasound and do a TIPS venogram, which is quite invasive, but that's when that is indicated. This was an interesting article that was highlighted to me. It's an article that looks at successful management of refractory ascites in non-TIPSable patients with percutaneous thoracic duct stenting. So in a patient that has the vascular accessibility is contraindicated, or this patient's not for liver transplant. They were looking at lymphatic drainage, and lymphatic drainage is important because the thoracic duct flow is 3 to 6 times more increased in a patient with cirrhosis. So looking at lymphovenous junction between the thoracic duct and the left subclavian, and actually putting a stent there to act as, to decrease the portal pressure. And that's the end of my talk. Thank you very much for the opportunity to present.